Hello there, this is Mary Roman, and in my brief talk today about pregnancy and Marfan syndrome, there are 4 topics I'd like to address. What is the magnitude of dissection risk? What is a safe aortic root diameter? Why do many dissections occur peripartum? And why do type B dissections occur? Before approaching these questions, though, I think it's important to keep in mind the limits to our knowledge base. First, there is a major publication bias in the early literature insofar as case reports and small series have resulted in an overrepresentation of complications. In addition, uniform diagnostic criteria have not always been used in the past, especially before the advent of genetic testing. Perhaps the most important confounder has been the fact that the diagnosis of Marfan syndrome was unfortunately made as a consequence of aortic dissection, and as a corollary, aortic diameters before dissections occurred are not always known, especially if the underlying diagnosis is unknown. As a consequence, dissection risk is overstated, as women with large aortic root diameters might have been discouraged from pregnancy without first undergoing elective root replacement. And finally, although more data are accumulating, robust serial imaging data before, during, and after pregnancy are still insufficient. So in terms of the magnitude of dissection risk, I'd like to look to a couple of large registries with which we've been involved. The first is the GenTAC registry, and in this analysis, we analyzed 227 pregnancies in 184 women with Marfan syndrome. Dissections occurred in 8 women, or 3.5% of pregnancies, including 4 type A dissections, 3 type B dissections, and 1 left main dissection. 6 of these dissections, or 75%, occurred in the postpartum period, which we define as the first 3 months following delivery, including all 3 of the type B dissections. Importantly, 3 of the 8 women, or 38%, were unaware of their Marfan diagnosis, and this is very similar to the occurrence of dissection in non-pregnant women, wherein 40% were unaware of their diagnosis at the time of dissection. These 2 bar graphs look at the lifetime impact of pregnancy on rates of aortic root replacement on the left and occurrence of aortic dissection on the right. As you can see, there was no significant difference in the rate of elective root replacement based on pregnancy status, whereas the rate ratio for dissection was 8.4. And this figure clearly overstates the risk since dissection may have resulted in the diagnosis. Next, I'd like to share with you data from our Cornell aortic aneurysm registry. In this instance, based on 147 pregnancies and 74 women with Marfan syndrome, and you'll see that the results are very similar. Dissections occurred in 5 women, or 3.4% of pregnancies, including 2 type A dissections in the 3rd trimester and 2 type B and 1 coronary artery dissection postpartum. Again, and importantly, neither woman with a type A dissection was aware of her diagnosis beforehand. And although I will not show you the data, a retrospective analysis by the Paris group published in 2009 described 6 dissections in 160 pregnancies, 3.8%, or very close to these 2 registries that I've described, and only 3 of these women, or 50%, were aware of their diagnosis. Now, the good news is that when women are aware of their Marfan diagnosis and are managed with a multidisciplinary approach, including a knowledgeable team, serial imaging, and use of beta blockade therapy, outcomes are much better and dissection risk is much lower. As you can see here from 2 contemporary series, one from Salt Lake City and one from Paris, there were no aortic dissections except for 1 type A dissection in a woman who was referred late and had an aortic root diameter of 47 millimeters, which is certainly above the safety threshold. So this brings me to the second question, which is what is a safe aortic root diameter before pregnancy is undertaken? There are two main guidelines. The first is the US recommendation of less than or equal to 40 millimeters. And the main basis for this recommendation dates back to a seminal paper by Reed Pieritz that was published in 1981. The TAD guidelines, published in 2010, include the following unreferenced statement. For patients with an aortic root diameter greater than 4 centimeters and Marfan syndrome, half will come to prophylactic aortic surgery during pregnancy, will have a rupture, or will have life-threatening growth. In contrast, the European recommendations, which were recently updated in 2018 but unchanged from previous recommendation, discourage pregnancy in women with root diameters of greater than 45 millimeters, but suggest that those with a root diameter in the 40 to 45 millimeter range may consider pregnancy in the absence of rapid growth or a family history of early dissection. At Cornell, we're up to about 55 observed pregnancies, and this slide includes data on the first 45. The graph shows aortic root diameter on the vertical axis and dimensions before pregnancy, during pregnancy, and after pregnancy. If we exclude the 4 pregnancies in women with roots over 45 millimeters, which were unsanctioned, if you will, you can see in the graph and in the table below that there was overall very little growth, including in the 40 to 45 millimeter range. Therefore, I think our data support the safety of the European recommendations, and I hope we can work together to revise the US consensus statements. So what are the potential causes of dissection, especially peripartum? There are 3 main hypotheses, and these include the oxytocin hypothesis described by Jen Habashi in the preceding lecture. Secondly, the impact of pregnancy-related hormonal changes on the integrity of elastic fibers, as demonstrated in pathologic specimens. And finally, the profound hemodynamic changes that occur as pregnancy progresses. So in this figure that provides summary data, you can see that there's a major increase in cardiac output, up to 40%, driven by increases in heart rate and stroke volume. Minimal overall change in blood pressure under normal circumstances, of course, and a major reduction in peripheral resistance down here in the blue. So in trying to understand the predilection for postpartum dissections, labor and delivery are associated with spikes in cardiac output, especially during contractions, as you can see in the blue line. And this is primarily due to increases in heart rate in the purple line, as well as increases in systolic blood pressure in the green line. And importantly, these changes in stroke volume and cardiac output persist into the postpartum weeks. So one final question is why type B dissections seem to predominate in those women who are aware of their diagnosis and do not have excessively large root diameters that might preclude safe pregnancy. Unfortunately, we have very limited data on pre-dissection descending aortic diameters to know whether pre-existing aneurysms are important, but limited data do not suggest that this is the case. And unlike the situation in the general Marfan population, there is not an association with previous elective aortic root replacement. And in fact, in a recent series published by Alan Braverman based on experience with 20 Marfan women followed at Washington University or Johns Hopkins who underwent pregnancy after proximal aortic surgery, none had pregnancy-related aortic dissections, although one woman did die of a type B dissection 1 year later. So this is clearly an area of great unknowns that warrants future investigation. And with that, I thank you very much for your attention, and I look forward to our discussion. My conclusions or takeaway points are indicated here on the final slide.